Let's get started. Let me turn off this. All right. So a 77-year-old female patient flew to Wisconsin on August 18 and returned this weekend, and she noticed vision loss in the right eye. Let me just move this square.
Oh, one sec. We got to pick somebody to discuss it.
Oh, yes.
Who's here? It's not presenting. Okay. Sabrina's going to do this one.
All right. So she had a cataract in the right eye. She thought the vision was probably bad from the cataract. Then the vision in the right eye got much worse. She has recently been getting more severe headaches. Her vision is now blank. She went to her old GP in Wisconsin who said it might be sinus pressure. Her chiropractor did an adjustment, and the chiropractor checked the patient's eyes and told her to go to the eye doctor. She has been feeling pressure around her eye since the air flight. Her meds include Cystane, Plavix, Combivent, aspirin, vitamin E, and zinc. Past surgical history include carotid surgery in 2000, a stent, and a mastectomy. Her visual acuity in that right eye is count fingers at 3 feet, and she's unable to see near. Visual or unable to detect near. Visual acuity in left eye is 20/25. She's J1. IOP is 18 and 16. She's pseudophakic OU. Right eye had rubiosis on the pupil margin and not in the angle.
So color from this photo of the right eye, the media is clear. The nerve might be a little bit cupped and maybe a little bit pale, but the vessels are very attenuated all over. And then there are some intraretinal hemorrhages kind of scattered throughout in the retinal septum. And then this is a bigger view of the right eye. Okay. I think in like the supratemporal periphery temporal area, there's some like, it's hard to make out the details, but some like RPE changes, maybe like a choroidal scar in that 9 o'clock spot. And then infranasal, there's some of those changes too, something in there. And then the left eye is so normal. So the vitreous or the media is clear. The nerve is pinker, the cup disc ratio is better. The vessels are normal caliber and not particularly tortuous, and then the retina, the macula looks flat and dry, and looks normal, looks clean. And then the periphery is normal. Okay, so these are OCTs of the right and left eyes. In the right eye, you have, this comparison to the left eye that just shows that there's a lot of retinal atrophy on the right side, or macular atrophy. You kind of lose some of the details of the intraretinal and outer retinal layers, just kind of overall. And the left eye looks normal.
It looks a little more inner than outer loss. Because you can see the white lines. It's not like a dystrophy patient. That's not a great OCT, but the white lines go all the way across the outer retina. Oh, there you go.
Okay, yeah, so you can make out the ellipsoid zone a little bit better here, and then it looks like outer nuclear, and then all the other stuff on top of it is so smushy and thin. And then the en-face view, the media is kind of hard to see. This is the same eye, but a vertical cut. That's correct.
Yeah.
Yeah, I would say same thing, just like a lot of diffuse inner atrophy.
Go back one slide.
You go back one.
Yeah.
In the nerve, you can see the cupping.
Yeah, there's some cupping. The other thing is, if you look at the inner retina, typically the nerve fiber would be bulging by the nerve, but the inner retina, it's a crummy image, but that's the best we get. The inner retina kind of looks about the same all the way across. So
on like pathology slides, they say like beam pot cupping.
Oh, okay.
Like that's what it kind of looks like, has that same shape.
Say that again?
Like in pathology, they say like beam pot cupping.
Beam pot?
Yeah, beam pot. It's like kind of like that. It's kind of like a pot. That's how pathologists have like a lot of food phrases to describe that. Or beam.
Okay, so this is an FA of the right eye. We're already past like the AV phase, getting into a little bit later.
Can you show the laminar phase? No, I don't think we got on this. We don't. The other eye's the eye.
All looks pretty normal. There might be like a little floater that's moving around. That's it. Okay, this looks like the right eye probably that's starting off. This is maybe before the choroidal filling phase.
Probably.
Choroid starting to fill. A little bit more. The vessels are so attenuated, so it's hard to tell exactly what stage this is, but they're filling. So
you can see the timer too. If you go back, the timer is actually pretty accurate. So if you go back to the beginning,
okay.
So that's 10 seconds. You can not see much, and then the choroid at 32.
So it's kind of delayed.
Yeah, delayed. Okay, keep going.
Yeah, so you have a lot of vascular filling defects. And I guess you'd call it blocking for the spots where the blood is.
Yes, there was some blood. Good. And that's 4 minutes.
I don't see any like NV or anything so far.
No, interestingly. She did have some iris though. There's
oh, yeah.
So that's 4 minutes, so that's kind of it.
Okay.
Why was the quality so poor to start and then it sort of cleared up?
Oh, got better. I think you're getting more fluorescein, so you're getting more signal. I mean, I think it's finally getting into something, so you're getting some fluorescein to shoot. I think before that, it really just wasn't. You're probably looking more autofluorescence earlier.
I think those are probably window defects supranasally, where the kind of pigmentary changes scars might be. Or
yeah, maybe. I think it's probably more autofluorescence. You're probably looking at it mostly an autofluorescence image. I think those are just scars.
Okay.
I gotta keep you guys on your toes. Little shout out to the Brady Bunch.
That's cool.
That's a good
So the differential would be like ophthalmic artery occlusion or central retinal artery. You could think about like really severe, if she's having headaches and stuff too, and she has carotid disease, so you could think about ocular ischemic syndrome, especially with more like the mid-peripheral retinal hemorrhages that she had. I forgot how old she was, but if she's also having headaches too, this could be like a manifestation of GCA. I don't know, it's something like that.
Yeah, right.
That's a really good differential. So the ocular ischemic syndrome, CRAO, CRVO, diabetic retinopathy, but absolutely GCA, and we'll talk a little bit more about the arteritis. This is ocular ischemic syndrome. And for this patient specifically, she had imaging of the carotids, re-imaging. Right carotid was seen to be 100% blocked. And then a left carotid stent was placed, treatment of the eye with Avastin alternating PRP. Her IOP remained under 20. So let's talk about ocular ischemic syndrome, which is a severe carotid artery occlusive disease that leads to ocular hypoperfusion. Symptoms can vary. They can have all of these, they could have only one of them, but they include vision loss, ischemic ocular pain, photophobia, amaurosis fugax. The mean age is typically around 65, men more than women. It's pretty rare disease, 7.5 cases per million per year. It's bilateral in 22% of cases. And poor collaterals between the internal and external carotid arteries or the right and left ICA can predispose you to getting OIS. May also appear in patients with different types of arteritis, including giant cell, aortic arch syndrome, Takayasu, any type of carotid artery dissection, hyperhomocystinemia, radiotherapy to the neck, thyroid orbitopathies, moya, as well as neurofibromatosis and scleroderma. So how do you diagnose? FA would show the delayed choroidal filling time, as you mentioned. It's the most specific angiographic sign and prolonged AV transit phase. And normal choroidal filling is usually 5 seconds. And in that patient specifically, I believe it was around 55 to 65 seconds. Staining often may imitate angiographic appearance of a frosted branch angiitis. Reason being is there's damage to the vascular endothelium over time, so they tend to leak. So it can look like it's autoimmune or some sort of inflammatory process. ICG would also show a choroidal filling time defect. ERGs would show a reduction A and B waves because both the inner and outer retina would be affected, as opposed to CRAO where only the B waves would be affected, at least for board purposes. And ophthalmodynamometry. I don't know if you guys have that at USF. I've never seen it performed, but it's basically when you put pressure on the globe to get an approximate pressure of the central retinal artery, and you would notice a decrease in that pressure. Diastolic readings.
Actually, you just do it with your finger.
You just do it with your finger?
I've rarely done it, but I have done it. It's kind of fun. You just look in with a 78 or a 90, and then you put your finger on their eye and you just like push until you occlude the artery.
Gotcha.
It's a little awkward and it can be a little uncomfortable for the patient, but it is, I have done it. It is an interesting test. When you say choroidal filling time, is that from arm to
No, from the first appearance to the dye.
Till it's full. Okay.
Yeah.
So I also think the arm to eye time is of some interest in people, especially when you do your own push. I'll bring a case later. I had a physician who, I can't remember what the angiogram was for. I think it was AMD. And he had a good vein. I pushed it in and didn't get to his eye for about 30 or 40 seconds, which is a little long. So he actually did carotid. He came back, he had an endarterectomy. And then we had me repeat the angiogram, which I said was great for teaching. It'll be a good teaching case. I'll probably bring it in later. But in the angiogram, the arm to eye time did speed up. So if I get a real slow arm, the other thing is slow arm to eye time has been giant cell arteritis is something I'm concerned about. But I would like 20 seconds. Normal's like 10 or 12, 15 maybe. 20 is not bad. 25 is like probably okay. Once it gets to be 30 or 40, you know, and the dye's just not getting to the eye, there's something a little weird going on. You know, you might have a really crummy vessel, but that's pretty slow to get to the eye. Anyway, sorry, go ahead.
No, that's good. And so when you're doing this ophthalmodynamometry with your hands, would you just compare the left and right eye to one another to see if there's vascular?
It seems pretty hard. Yeah, you can mirror the eyes, or you can just say, gosh, that was easy to occlude. Like you just pat the eye and it's like, whoa.
Okay.
Sounds you know good, where we do that too now is intravitreal injections. You know, if people are constantly blacking out after the intravitreal injections, you get a little nervous about that. Because we do those constantly.
I don't want to go too much into all of these things, but just since ocular ischemic syndrome, CRVO, and diabetic retinopathy look so similar sometimes, it's just important to kind of get an understanding of what are some main differentiating factors. So in OIS, you would not have tortuosity as opposed to a CRVO. Other things would include the optic disc is definitely something to look for. It would typically look normal, maybe a little pallorous in ocular ischemic syndrome, where a CRVO would be edematous. What else? Yeah, so with FA is really how you make, it's the gold standard. So it would be prolonged pretty much in both of these. And the macedema, you can get it with OIS, but it's just pretty rare.
Since you brought it up, in CRVO, the optic nerve is always edematous. It's actually a nice sign to have in your back pocket if you're trying to differentiate things. Right. It's always got to be high.
Right. Whereas it's pretty rare in diabetic retinopathy, only when you get papillopathy. And so the workup would also include carotid evaluations. And so the carotid duplex ultrasound is this, and MRI and CTA are gold standards. The ultrasound combines both B mode ultrasound and Doppler ultrasound, so you can get a visual image of the vessel as well as flow velocity. MRA and CTAs, what we kind of jump to when we usually in private practice just have the patient follow up outpatient with their cardiologist, while at the same time we order MRA and CTA. I don't know if you guys order the carotid duplex and the second one as well. And carotid arteriography is no longer the gold standard. It used to be, but there's just an increased risk of stroke and MIs. So pretty much no one gets these for this kind of condition, since CTAs are excellent. So treatment for ocular wise, you would use ocular hypotensive agents and and cycloplegics. You would avoid anything that might be pro-inflammatory, including prostaglandins and pilocarpine. You could use PRP and anti-VEGF if you see ocular neovascularization. And surgery often required for neovascular glaucoma. They don't usually respond well to just IOP lowering drops. Chronically painful eye, you can do retrobulbar alcohol or retrobulbar chlorpromazine. I've actually never injected this. Do you guys at USF inject a retrobulbar chlorpromazine?
I've never heard of that.
No, we talk about doing alcohol sometimes for patients who have like blind painful eyes, but not chloroform.
Yeah.
If you
All
do
right.
inject alcohol, be really careful not to get a brainstem alcohol injection. That's like one of my nightmares. So I've done alcohol some, but if you're doing it, you're supposed to, which is almost impossible. You're supposed to put the needle in, inject some anesthetic because the alcohol hurts like hell. And then you're supposed to take your syringe out or do a stopcock, give it a second, make sure they're not getting a respiratory arrest from your shot, not move the needle, which is impossible, and then push the alcohol through the same needle.
How do you inject the brainstem by accident?
The cavernous sinus.
No, you can go through the sheath. I've done it. I just wrote a paper on that too. I've done it 3 or 4 times. If you do, are you doing any retrobulbar shots?
Barely, just like in plastic, sometimes pre-op or
Yeah.
post-op.
This all we used to do is retrobulbar. So a lot of our younger doctors aren't good at it, but you can do a retrobulbar shot of getting the optic nerve sheath, and then they get a brainstem block. And it's interesting, just so you know this, if you do a retrobulbar and the patient starts to act goofy, I always have people sit with them for 5 minutes. And if they start to act goofy, then I have them call me. I said, don't get them up. I had one person I was blocking for a laser, and he said, is this supposed to affect the other eye? And I was like, no, it's not. So that meant it was getting back to the chiasm. And then what'll happen is as opposed to a vagal response, they'll actually they'll get weird, but they'll get a high heart rate and their blood pressure will go up. So if someone's getting weird after a retrobulbar and you check their heart rate and it's up, that means they might be getting a brainstem block. The anesthetic's a little heavier than CSF, so if you lean them forward and put them on oxygen, they're okay. And then maybe call 911. We had a patient in one of our offices actually die. This was not my patient, where it was a 50-something-year-old woman, one of the older doctors had blocked. She got a respiratory arrest. And then what happened was she started to get a reaction. And the natural thing when someone gets a reaction is to lay them on their back. But if they're getting a brainstem block and you lay them on their back, it goes right to the respiratory center and the respiratory arrest. So they'll stop breathing. And then the EMTs did a bad intubation and intubated her esophagus. And she was dead on arrival at the hospital, which really sucked. They should have just masked her. But anyway, so you can get a brainstem block. And I've had like 5. They're kind of weird. And I've had them in the office in the OR. If you in the OR, you can just go ahead and do the surgery. You can convert to general and do the surgery, but I don't think I ever had the nerve to do that. But anyway, so you can get brainstem blocks.
Fair enough. Fair enough.
Yeah. So then with alcohol, that's like if you got a brainstem alcohol, I don't know what would happen. That would be, I think, fatal. So that's why the alcohol blocks kind of freak me out a little bit.
Let me show you guys the beatbox. That's what a beatbox is like.
Oh yeah, this is like the cup.
That's like the pathology version.
You can't see this on the internet, but he's looking at the cups as the pathology. All right, go ahead. Sorry to interrupt you. Yeah, no problem. And so vascular wise, carotid endarterectomy is usually performed on patients who are 50 to 99% in symptomatic stenosis or 60 to 99% asymptomatic stenosis. I think they test this on this and our boards. Carotid artery stenting, extracranial and intracranial artery bypass surgery can be performed, which is when you create an anastomosis between the superficial temporal artery with a branch of the MCA. I've never seen a patient who had this experience, but I saw in the literature. Prognosis, 50. Someone have a question?
One thing that one of our glaucoma attendings told us before, so if in this patient, if she had the right eye ocular ischemic syndrome and the blockage wasn't 100%, but it was somewhere less than that, and they did an endarterectomy, they're super high risk with reperfusion having like skyrocket IOP. So they would that glaucoma specialist said that he likes to know like when they're doing the endarterectomy, and he wants to see the patient as soon as possible after, and maybe consider like a tube and putting them on meds, even without seeing the patient, just because the risk is high after the reconstruction.
Yeah, that's a really good point. Yeah, you can definitely have any type of spontaneous hyphema, retinal hemorrhages right after these procedures. Absolutely. And prognosis.
Probably perfusion of the ciliary body. I think you probably reperfuse your ciliary body.
Is that what it is?
Probably. That's the thing about these cases. Like this lady's pressure wasn't high. A lot of the ocular ischemics, their pressure, their eye looks like crap and the pressure's not high. And I think it's because the ciliary body is also hyperperfused. I think.
And so prognosis, 50% of patients are usually count fingers by 1 year. Worst prognostic factor would be any type of neovascularization of the iris. Overall mortality of these patients with OIS is 40% at 4 years, and MIs account for the vast majority of them for 2/3. And that's it. Thank you, guys.
So I have a question. So are you, what's standard of care for carotid now? It's not ultrasound anymore?
Dr. Drucker doesn't like it because he always says like it stops at the jaw and you're not getting any of the cerebral vessels with the ultrasound. I don't know if like in evidence-based medicine, you do the ultrasound first, and if you had a high suspicion and that was a negative, then go for the CTA just as
agnostic. So I think the ultrasound's the common thing because that's something you can treat. I don't know if you can treat. If you can't ultrasound, I don't know if you can fix it. Can you fix high up? Can you bypass and stent? I guess you can stent, right? Maybe you can stent. I always thought ultrasound was the standard because if you found something outside of that area, you couldn't fix it anyway. So then you get a CTA or an MRA? CTA? Interesting. Okay. I don't think that's true in my community. Oh, that was excellent. Thank you. And very good. That's awesome.
Thank you, guys.
Dan, can you go back to the fundus photo?
Oh, sorry. I can put it back up.
Oh, so on this lady, I'm maybe asking her PRPing now. And she's light perception. Oh, the other thing I was to say is I don't believe in if someone's got light or hand motion or count fingers, I don't think you should just let the eye die. You know, so I think it's worth treating. I've even put valves and PRPs. I do valves in PRPs in patients with count finger vision. So this lady I'm PRPing now, and I was wondering if I should just PRP through her phobia because she doesn't have a phobia, but I'm still going to do a standard PRP. I'm going to see if that takes care of it. So sorry, go ahead.
Yeah, can you go back one more picture?
Mm-hmm.
So with all the hemorrhages, it's typically not common for OIS to have it like very posterior, right? And then usually with CRAOs, we don't see that often either.
Right.
With the hemorrhages. So I was wondering what your thoughts were on that.
Me or Sam?
You.
Oh. I think this happened a while ago. Yeah. So it's not acute. I think the eye's just, I think it's just all messed up. I mean, you can see an intraocular plaque there. Mm-hmm. So it's not, so it's kind of a hybrid. And there are hybrid like artery vein ischemic. I think she's just included everywhere. Yes, but it's true. And I think maybe she's not so far peripheral because she's so ischemic. Mm-hmm. So I think typically it's true. Your hemorrhages are more in the periphery. And I think the hemorrhages are more like watershed. And I think in her case, the watershed zone is posterior because she's so occluded. It's true if you see temporal, like you didn't mention this, but one of the things that I worry about with ocular ischemic is when you see hemorrhages temporally, because that's where your kind of watershed, where your core perfusion is. So if I see, temporal hemorrhages in one or both eyes, and that's it, I'll sometimes worry about oculars, mild ocular ischemia.
Oh, I was actually wondering on the FA, in like the fever picture that we saw in the quiz, how you have that really sharp demarcation of cord perfusion. I think you don't really see that on the FA.
This one?
Yeah.
Oh yeah, it's true. Some of them don't show capillary. That's why it's true. This may be everything. This may be, but ocular ischemia, sometimes it's just real slow to get in, but you don't get the clipping. It's not that common. I'm trying to think of the ones I've seen. I've had some where they're just recurrent hemorrhage and they're not really, the eye looks pretty normal. And sometimes, I've seen, and then sometimes it's rubiosis without much findings. It seems to be a smattering of things. I think this patient I think Nisar's right. This probably is a combination. Artery occlusion, vein occlusion, ocular ischemic syndrome. It's probably all three.